Welcome back to the deep dive. Today we're tackling a really complex but vital area in cardiology, the pharmacology of antiarrhythmic drugs, often called AADs.
Yeah, these drugs are powerful. And the conditions they treat, arrhythmias, these abnormal heart rhythms, well, they run the gamut.
Right, from completely asymptomatic, something you just find on an ECG, to causing severe heart failure or even sudden cardiac death. We're talking tachyarrhythmias too fast or bradyarrhythmias too slow.
Exactly. And, before we even think about putting someone on a long-term drug, the first absolutely critical step, stressed in all our sources, is looking for reversible causes.
Like what? Electrolytes.
Precisely. You got to check potassium, magnesium levels, make sure another drug isn't causing toxicity. You correct those things.
That's the underlying problem if you can.
Yeah.
Okay, but sometimes you can't, or the issue is chronic. That's where AADs come in.
So our mission today is to really unpack the basic cardiac electrophysiology, how these drugs actually work at the cellular level.
And then we'll walk through that famous, or maybe infamous, Vaughan Williams classification system.
And look at the profiles of key drugs, how they work, side effects, those crucial clinical pearls. And finally, follow the decision pathways for common arrhythmias like AFib and VT.
Okay, let's unpack this electrophysiological blueprint. It all comes down to the cardiac action potential, right? That's what these drugs target.
Exactly. We're talking about the non-pacemaker cells here, the main heart muscle cells. They have a resting membrane potential around negative 90 millivolts, very negative.
And the electrical signal causes this dramatic change. What are the key phases?
Okay, so phase 0 is this incredibly rapid depolarization. It's driven by a massive, very fast influx of positive sodium ions, Na plus, bang, the cell fires.
Super fast.
Then after a little dip, you get phase 2, the plateau. This is really interesting. The cell stays depolarized because there's a balance. Potassium ions, K plus, are flowing out, but calcium ions, Ca2 plus, are flowing in.
And that plateau phase is really important for contraction duration, isn't it?
Absolutely. Manipulating that phase is a key target for some drugs. Then comes phase 3, repolarization. The calcium channels close and potassium efflux dominates, bringing the cell back down towards resting potential.
Getting ready to fire again.
And phase 4 is that resting phase. Although in pacemaker cells, this is where you see that slow, gradual depolarization that gives them their automaticity.
Got it. So arrhythmias happen when this smooth electrical process goes wrong. Either the impulse doesn't form correctly.
Right, like increased automaticity, where cells fire on their own when they shouldn't, or these things called after depolarizations, often triggered by calcium overload.
Or the impulse doesn't conduct properly through the heart tissue.
Yeah, and the big one there is reentry. That's the mechanism behind a lot of tachycardias. It needs basically 2 pathways for the signal, but one path is slow, and the other path has a block in one direction only.
So the signal can just loop around and around.
Exactly. Creates a short circuit driving a rapid rhythm.
Clinically, we usually split arrhythmias into supraventricular and ventricular, right?
We do. Supraventricular means they start above the ventricles in the atria, the SA node, the AV node. Often these aren't immediately life-threatening, but they can definitely reduce cardiac output and cause symptoms.
Whereas ventricular arrhythmias, starting in the ventricles or the His-Purkinje system, those are usually more serious.
Often, yes. They're frequently symptomatic, sometimes require immediate treatment, and are often linked to underlying heart disease like ischemia, previous heart attacks, or cardiomyopathies.
Okay. Understanding those targets helps make sense of the drugs. Let's talk about the Vaughan Williams classification.
Right, the Vaughan Williams system. It's the most common way we group these drugs, based mainly on their primary electrophysiologic effect. But it's not perfect.
How so?
Well, some really important antiarrhythmics like digoxin, adenosine, atropine, adarian, they aren't even in the system. And some drugs, like amiodarone, famously have properties of multiple classes.
Okay, but it gives us a framework. Here's where it gets really interesting, right? The 4 main classes.
Let's quickly outline them. Class I drugs block sodium channels, primarily affecting that fast phase 0 upstroke.
Class 2.
Those are your beta blockers. They mainly slow things down at the SA and AV nodes. Indirect effect, really, by blocking catecholamines.
Class 3 drugs target potassium channels. They work mostly on phase 3, prolonging repolarization.
Correct, which means they lengthen the action, potential duration, and the QT interval on the ECG, a really important point we'll come back to.
And finally, class 4.
Those are the non-dihydropyridine calcium channel blockers, verapamil and diltiazem. They slow conduction, mainly in the SA and AV nodes, by blocking calcium influx during phase 2 and phase 4.
Let's dive into class 1, the sodium channel blockers. They're subdivided.
Yes, into IA, IB, and IEC, based on how quickly they attach to and detach from the sodium channel. This dissociation kinetics is key.
And they all show rate dependence.
Right, meaning their blocking effect is generally stronger when the heart rate is faster. They work better during tachycardia.
Okay, so class IA, like quinidine, procainamide, intermediate dissociation.
They block phase 0 sodium influx, but also have some class 3 activity, prolonging repolarization. Kind of broad spectrum.
Class IB, like lidocaine, fast dissociation.
Very fast. They bind and unbind quickly. This makes them more effective on channels that are frequently opening, like during ischemia or in already depolarized tissue. More selective for ventricular tissue.
And class IC, flecainide and propafenone, slow dissociation.
Very slow. They latch onto the sodium channel and stay there longer, causing significant slowing of conduction velocity throughout the heart. Very potent.
Let's get into the specific drugs now, starting with class IA, quinidine. It's broad, but you mentioned anticholinergic effects?
Yes, and that's a huge clinical pearl. Quinidine can actually speed up conduction through the AV node because of that anticholinergic effect.
Yeah.
So if you give it to someone in AFib or Flutter,
It could make the ventricular rate faster. That sounds dangerous.
it is. That's why you absolutely must control the AV node first with something else, a beta blocker, a non-DHP calcium channel blocker, or digoxin, before starting quinidine for those rhythms.
Plus, it has GI side effects, risk of torsades de pointe, and major drug interactions like doubling digoxin levels. Seems tricky to use.
It demands a lot of respect and careful management, definitely.
Yeah.
Procainamide, another IA, is mainly IV now. Its metabolite, NAPA, actually has class 3 effects.
So potassium channel blocking from the metabolite.
Right. And both the parent drug and NAPA accumulate in kidney disease, so you have to monitor levels closely.
Okay, moving to class I lidocaine. You said it's selective for ischemic tissue.
Yeah, that fast dissociation means it prefers to bind to sodium channels that are either inactivated, like in depolarized ischemic cells, or opening frequently, like in rapid VTACH. So its prime use is for ventricular arrhythmias, especially after a heart attack.
But didn't you say earlier it's not used prophylactically post-MI?
Correct. Clinical trials showed it didn't improve survival when given routinely after MI to prevent VTVF and might have even increased mortality. So we only use it to treat active ventricular arrhythmias.
And watch out for CNS side effects.
Definitely. Dizziness, confusion, seizures, especially in elderly or those with heart failure or liver disease because its clearance is reduced.
Now for the big one, class AADs, flecainide and propafenone. Very effective for supraventricular stuff like AFib.
Incredibly effective. But here's probably the single most important warning in AD therapy.
The CAFIST trial.
Exactly. The cardiac arrhythmia suppression trial. It showed that in patients with structural heart disease, meaning coronary artery disease, previous MI, heart failure, significant LV hypertrophy, using flecainide or similar drugs to suppress even benign-looking ventricular ectopi, actually increased mortality.
Due to proarrhythmia causing lethal ventricular arrhythmias.
Precisely. So the absolute rule is class IC drugs are contraindicated in patients with any structural heart disease. Full stop.
Wow, okay. Propafenone also has some beta blockade too, right?
Mild beta blocking properties, yes. Another thing to keep in mind.
Let's shift to class 3, the potassium channel blockers. Amiodarone is the big one here.
Amiodarone is. Well, it's practically in a class of its own. It has properties of all 4 Vaughan Williams classes. Block sodium, beta receptors, potassium, and calcium channels.
What's the main clinical advantage of that?
Its biggest advantage is that it has very little negative inotropic effect. It doesn't weaken the heart muscle significantly. This makes it one of the very few AADs considered safe to use in patients with heart failure with reduced ejection fraction, HFrEF.
But the trade-off is toxicity.
A huge trade-off. It's extremely lipophilic, it's everywhere in the body, has a massive volume of distribution, and a ridiculously long half-life, often over 50 days.
Meaning side effects can take ages to appear and ages to resolve.
Exactly, and the side effects are serious. Pulmonary toxicity, which can be fatal, requires baseline and follow-up chest x-rays and PFTs. Thyroid problems, both hypo and hyperthyroidism because it's loaded with iodine.
Corneal microdeposits.
Almost everyone gets those, though usually not affecting vision significantly. Liver toxicity, skin discoloration, and major drug interactions.
Like with warfarin and digoxin.
Yes, it inhibits CYP enzymes. You generally need to cut the warfarin dose by about 1/3 and halve the digoxin dose when starting amiodarone. You have to be incredibly careful.
Then there's dronedarone. Related, but different.
Right. It's structurally similar, but without the iodine atoms, and a much shorter half-life, around 24 hours. Less thyroid, and perhaps less non-cardiac toxicity overall.
But it has its own major warnings.
Big ones. It's contraindicated in patients with severe heart failure, NYHA class 4, or recently decompensated class 3, and also, crucially, in patients with permanent atrial fibrillation. Trials showed it increased cardiovascular death and stroke in those groups.
So not for everyone. What about sotalol?
Sotalol is interesting. It's both a non-selective beta blocker and a class 3 potassium channel blocker.
Dual action.
And it shows reverse use dependence. Meaning its potassium channel blocking effect, the part that prolongs the action potential, actually gets weaker at faster heart rates.
Yeah.
The opposite of rate dependence seen with class 1 drugs.
Okay. And it prolongs the QT interval.
Significantly and dose dependently. Risk of torsades de pointe. It's renally eliminated, so dosing is based on creatinine clearance, and it's generally avoided in AFib if CRCL is below 40. And like dofetilide, starting it requires a mandatory 3-day hospital stay for monitoring.
Dofetilide, another pure K+ blocker, safe in HFrEF.
Yes, dofetilide is a selective potassium channel blocker, and importantly, it is considered safe in HFrEF, like amiodarone. But it also carries a high risk of TDP, needs that 3-day inpatient initiation, and dosing is strictly based on creatinine clearance contraindicated if CRCL is less than 20.
Finally, class 4, verapamil and diltiazem, non-DHPs.
Primarily used for rate control in supraventricular tachycardias like AFib by slowing AV node conduction.
But definitely not for everyone.
Absolutely not. 2 key contraindications. Patients with HFrEF, because they are potent negative inotropes and can worsen heart failure, and patients with Wolff-Parkinson-White, or WPW syndrome.
Why WTW?
Because in WPW, there's an extra electrical pathway between the atria and ventricles. If you block the normal AV node pathway with verapamil or diltiazem during AFib, you can force all the rapid atrial impulses down the accessory pathway, potentially leading to very fast ventricular rates, even ventricular fibrillation. Very dangerous.
Okay, that covers the main drug classes. Now, how do we put this together in practice? Clinical decision-making.
It always starts with 2 questions. 1, is the patient stable or unstable? 2, have we looked for and treated any reversible causes?
Let's take atrial fibrillation or Flutter. If the patient is unstable, hypotensive, altered mental status, chest pain.
Immediate synchronized cardioversion. Shock them back into rhythm, no time to waste.
If they're stable, but the heart rate is too fast, we need rate control first, right?
Usually, yes. And the choice depends heavily on their left ventricular ejection fraction, the LVEF.
If LVEF is good, say over 40%.
Then you can typically use an IV beta blocker or IV diltiazem or verapamil. They work well to slow the AV node.
But if LVEF is low, 40% or less, HFrEF.
Then you absolutely avoid verapamil and diltiazem because of their negative inotropy. Your options for acute IV rate control become IV digoxin, or sometimes IV amiodarone, though amiodarone also has rhythm control properties.
And for long-term management, it's often a choice between trying to maintain normal rhythm control, or just controlling the rate and leaving them in AFib, weight control.
Exactly. And major trials have shown that for many patients, especially older ones or those with persistent AFib, a rate control strategy is just as good in terms of outcomes like stroke and mortality, and often safer given the toxicities of long-term AADs used for rhythm control.
But if you do go for rhythm control, or if someone needs cardioversion, anticoagulation is key.
Absolutely critical. If AFib has been present for more than 48 hours, or you don't know how long, there's a significant risk of stroke when you convert them back to sinus rhythm, because clots might have formed in the left atrial appendage.
So you need anticoagulation first.
Yes. Either at least 3 weeks of therapeutic anticoagulation with warfarin or a DOAC before cardioversion, or you do a transesophageal echo, TEE, right before to rule out a clot. And either way, everyone needs at least 4 weeks of anticoagulation after successful cardioversion.
And long-term stroke prevention is guided by
the CHA2DS2 VACO score. It calculates stroke risk based on factors like congestive heart failure, hypertension, age, diabetes, prior strokedia, vascular disease, and the sex category. A score of 2 or more in men or 3 or more in women generally means long-term anticoagulation is needed.
Okay, shifting gears to ventricular tachycardia, sustained VT, unstable.
Same as unstable AFib, immediate synchronized cardioversion.
Stable VT.
For stable VT, IV antiarrhythmics are the first step. Options include IV procainamide, IV amiodarone, or IV sotalol. 4-etiquane is an alternative, especially if ischemia is suspected.
And for chronic prevention of VT.
Devices are king here. An implantable cardioverter defibrillator, an ICD, is usually first-line therapy for secondary prevention after sustained VT or VF.
AADs are used mainly as backup.
Primarily as adjunctive therapy. If someone with an ICD keeps getting shocks, you might add an AAD, like amiodarone, often with a beta blocker, or sotalol, to try and reduce the frequency of VT episodes. Or if a patient refuses an ICD.
And the ultimate emergency, pulseless VT or ventricular fibrillation, cardiac arrest.
That's the ACLS algorithm, high-quality CPR immediately, defibrillation as soon as possible.
If the first shock doesn't work.
Continue CPR, establish IV access, and give a vasopressor epinephrine.
And if VTVF still persists after more CPR and another shock,
then you consider an antiarrhythmic. IV amiodarone is usually the first choice, or IV lidocaine as an alternative.
Wow. Okay, so wrapping this up, the big picture seems to be careful drug selection based on the underlying heart condition.
Absolutely. If we connect this to the bigger picture, you must match the drug to the patient. HFrEF means you lean towards amiodarone or dofetilide. Structural heart disease means you absolutely avoid class A drugs, avoiding non-DHPs in HFrEF and WPW. These aren't suggestions, they're critical safety rules.
And these drugs have narrow therapeutic windows.
Extremely narrow. Toxicity is a constant concern, even with normal doses, which makes patient education incredibly important.
What do patients need to know?
They need to monitor their heart rate, blood pressure, daily weight for fluid retention. They need to know the warning signs, dizziness, fainting, new or worse palpitations, shortness of breath, and report them immediately. And they need to be so careful about drug interactions, even with over-the-counter stuff or herbal supplements like St. John's wort or licorice. Even generic substitutions sometimes warrant caution.
This raises an important question, especially thinking about older adults.
Yeah, the geriatric population is uniquely vulnerable. Kidney function declines, liver function can decline. They're often on multiple medications already. Polypharmacy is a huge issue.
Which increases the risk of AAD toxicity, like with digoxin.
Dramatically. And what's really challenging is that the symptoms of toxicity, confusion, weakness, fatigue, loss of appetite can be easily mistaken for just getting older or dementia.
So a side effect gets missed because it's attributed to aging.
Exactly. It requires really careful baseline assessment before starting these drugs in older adults and just constant vigilance and reevaluation to make sure we're helping, not harming. That's a crucial final thought. Don't mistake drug toxicity for the normal aging process.
That's a powerful point to end on. Vigilance is key. Thank you so much for walking us through this incredibly complex topic. It's clear these drugs require deep understanding and respect.
My pleasure. It's vital information for anyone managing these patients. Thanks for listening.